Good morning, everyone. This is Mark Erkin from New York. Welcome to Thyroid Multidisciplinary Seminars. I have the distinct pleasure this morning of introducing Dr. Jen Perkins, who is endocrinologist and professor of clinical medicine. She holds a joint appointment in the Department of Medicine and Surgery at University of California, San Francisco. She is the Associate Director of Endocrine Neoplasia Destination Program, and she also serves as Associate Chair of Medicine for Ambulatory and Population Health. She is also at this time wearing the hat of Ambulatory Executive Medical Director for the medicine specialties, as well as for UCSF Health Access Services. So she is incredibly busy, and at this time, we are incredibly grateful for her not only getting up very early on the West Coast, but taking time out of her schedule to join us. So as always, I'd like to encourage all of you who are listening to send in your questions, and I will do my very best to get to them before the end of the hour. Dr. Perkins, thanks once again for carving time out to join us this morning.
Thank you very much. Let me just share my slides. I will do my best not to have an early morning speech impediment. Okay, great. Well, thank you so much for having me. It's a pleasure to be here. I don't have any financial disclosures. I did want to provide a special acknowledgement to Dr. Stephanie Fish and Dr. I.L. Robenstock, as a portion of this presentation was used during our presentation at the annual ATA meeting in 2022. So just as an agenda, we'll briefly talk about how treatment options have evolved, what the landscape looks like for total thyroidectomy versus lobectomy. We'll use a couple of cases to look through when to stop at lobectomy, when to consider completion radioactive iodine, and what the evidence does to support that, and how some of our surveillance strategies are a little challenging. So before we get into that, let's just start where we're at in this was about 2020, but thyroid cancer incidence, as we all know, increased for decades and decades, and was thought at one point in time it was going to move from the 5th most common cancer in women to the 3rd. And you can see it's kind of leveled off and slowed down. Particularly papillary makes up most of that growth. And why is it leveling off or decreasing? Probably there's a lot more following of the guidelines. Hopefully people are ordering less ultrasounds or less biopsies for small, non-concerning thyroid nodules. We did declassify NIFT-P as a malignancy and into an indolent tumor, so that dropped off several cases. So it'll be interesting to see over time where this curve goes, but it looks like we've stabilized that rapid growth. And then what about treatment options? So when the 2009 guidelines came out, as I was starting my world of being an attending physician, they used to recommend total thyroidectomy or subtotal thyroidectomy for any papillary differentiated thyroid cancer over 1 centimeter. And then for the first time when the 2015 guidelines came out, we were advised that actually there's some pretty good evidence if it's under 4 centimeters with no extrathyroidal extension and no clinical evidence of any lymph node metastases, we can consider a thyroid lobectomy. And certainly if we do surgery for papillary microcarcinomas, lobectomy should definitely be the choice of surgery or versus active surveillance without surgery. So a big pendulum swing. And when we consider lobectomy versus total thyroidectomy, we have a lot of considerations to put in the balance between the surgeon and the endocrinologist and the patient. Sometimes if we need to do a lobectomy, the pathology can be surprising and we need a 2-step procedure, which can be challenging for the patient. It can present surveillance challenges, which we'll talk a lot about today. There's always patient preferences. We all have those patients that even if there's a 1 centimeter TI-RADS, 2 TI-RADS, 3 nodule on the other side, they're very risk averse and want a total thyroidectomy. There's costs associated. There's more risks with a total thyroidectomy versus a lobectomy. And then we always never want to undertreat. So I think it's really important to sit down and have some discussions and use the data you have. And certainly a good preoperative ultrasound when making the decision of whether to start with a lobectomy or a total thyroidectomy. So what's happened over time in terms of surgical approach? This is a line for lobectomy and the percent lobectomy based on tumor size. So you can see over here, the micro tumors, microcarcinomas have leveled off, and hopefully that's because people are not operating as much and maybe putting more into active surveillance. But we've seen a big growth in lobectomy as a choice in patients and tumors less than 4 centimeters. So growth in all of those size differences. And some of the important things to think about is there's a lot less post-operative emergency room departments, visits for hypocalcemia, less hypoparathyroidism. So I think it's all a balance of pros and cons. The risk of having a two-step procedure, the higher risk of needing, obviously the risk of needing thyroid hormone if you have a total thyroidectomy versus a lobectomy, et cetera. And not only is lobectomy going up in the blue line, but so isn't total thyroidectomy without radioactive iodine. And radioactive iodine is tanking. So it's very reassuring that people are starting to follow the guidelines. And I think we're doing a better job of it because we know radioactive iodine won't impact outcomes in almost all of our low risk patients and probably some of our intermediate risk patients. But what does this do for the person who's following these patients? Perhaps that's an endocrinologist. You know, a lot of our data, a lot of our guidelines are based on parameters after a patient has had a total thyroidectomy, after they've had radioactive iodine. So things like thyroglobulin become very challenging, if at all to use, and the strength of our evidence wavers a little bit when we're talking about lobectomy versus total thyroidectomy with or without radioactive iodine. So definitely need to rely on the strength of our evidence and understand what challenges it presents. So let's start with a case. This is a 68-year-old female who was found to have a left thyroid nodule noted incidentally on carotid ultrasound, very common. Ultrasound showed a little bit heterogeneous thyroid gland, an 8-millimeter right mid-pole nodule, which is TIRADS 3, and a 2.3 centimeter left mid-pole TIRADS 3 nodule, no abnormal lymph nodes seen in the central or lateral compartments. So we biopsied the left mid-pole 2.3 centimeter nodule, and it was diagnostic of PTC or Bethesda 6. This patient underwent a left hemi-thyroidectomy. Pathology showed a 2 centimeter follicular variant PTC, encapsulated with extensive capsular invasion, no vascular invasion, no extrathyroidal extension, negative margins. There is an additional 3 foci of micro PTC, ranging from a size of 0.3 to 0.6 centimeters. There is also an incidental finding of chronic lymphocytic thyroiditis. 6 weeks after surgery, they're not on levothyroxine. TSH is 3.2. Thyroglobulin was checked and it was 24.5 with negative antibodies. 6 months after surgery, still not on levothyroxine. TSH is 2.86. Thyroglobulin is 25.8. TG antibodies remain negative. Ultrasound shows no left bed thyroid nodules. The right lobe is heterogeneous with stable TIRADS 3 nodule measuring up to 9 millimeter and no abnormal lymph nodes. 5 years after surgery, not on levothyroxine, TSH is 2. Thyroglobulin is 42, so rising from baseline. And ultrasound shows that right-sided thyroid nodule grew a little bit and is now 13 by 9 by 12 millimeters, but still TIRADS 3, no abnormal lymph nodes. So it raises some questions. Are we concerned about the rising thyroglobulin level? Would we recommend an FNA of the growing right thyroid nodule? Would you recommend completion thyroidectomy? What is this person's TSH target? And does multifocality on the original pathology predict contralateral lobe disease? So let's start with some of those. I'm going to move pictures just so I can see the whole slide. Give me 1 sec. There we go. So in the 2015 guidelines, the thyroglobulin cutoff points for patients with lobectomy was weak evidence and said they really need to be defined. We had this paper in JCM in 2016 that suggested an excellent response was a stable non-stimulated thyroglobulin less than 30 in people who have undergone lobectomy with undetectable TG antibodies and negative imaging. We know upwards of 25% of patients have thyroglobulin antibodies, so for a large percent of the population, this can be even more challenging than what I'm presenting here. In this study, those that showed an excellent response, as by that definition, 0 out of 120 patients had recurrent or persistent disease. Those with a biochemical incomplete response rising above 30, 33% were found to have recurrent persistent disease. A couple other studies looking at thyroglobulin post-lobectomy showed some conflicting data. Park et al. and Thyroid 2018 showed that in a lobectomy patient, TG increases gradually during follow-up, and that's with or without recurrences, making it quite unreliable. This Ritter study was well done and showed that thyroglobulin didn't really correlate too much to initial tumor characteristics. It can be elevated with contralateral nodules, Hashimoto's, and didn't correlate very well, and showed limited value of predicting or detecting recurrence. So you could see that out of 12 patients that were recurrent, only 2 had a thyroglobulin greater than 30. In the 155 that did not have recurrent disease, 11 patients had thyroglobulin levels greater than 30 up to 103. And then Zhu et al. And Thyroid 2021 thought, well, maybe thyroglobulin is helpful with a threshold of 11. So lots of conflicting evidence. And then this meta-analysis was published more recently, and it really aimed to look at 3 questions. Is circulating thyroglobulin reliable to assess the early response, meaning no recurrence within 24 months? Is circulating thyroglobulin predictive in hemi-thyroidectomy as it is in total thyroidectomy without RAI? Is circulating thyroglobulin reliable to detect persistent recurrent disease after lobectomy? And really, it was not. There was a lot of interpatient variability, overlapping thyroglobulin levels. Thyroglobulin was found to increase over time, regardless of recurrence, so it was not felt to be a marker of recurrence. The authors did feel there's a potential in those really high values, over 100, that could raise a red flag of recurrence, but not reliably. And their conclusion was data does not support thyroglobulin for monitoring low-risk DTC treated with lobectomy. So that answers that question, sort of. Would you recommend an FNA of the growing right thyroid nodule? Previous studies demonstrate that contralateral papillary thyroid cancer exists in 12 to 40% of cases. But really, a lot of things matter when making these decisions: the size, the ultrasound characteristics, the extent of the disease. This study showed that it was more predictive, obviously, and this makes a lot of sense. If you had lymph node metastases, the tumor was larger, you had ipsilateral multifocality, and obviously had a contralateral benign nodule. Things that were not predictive in this study: Hashimoto's, BRAF positive, capsular invasion, sex or age greater than 55, and extrathyroidal extension. This study by Robin-Schock et al. Looked at 112 lobectomies with contralateral nodules. The median size was 7 millimeters, but with a range up to 30 millimeters. And they followed them for 6 years. 11% underwent completion, and of those 11%, only 5% had contralateral PTC. So it was really found to be similar to patients without nodules. This is a study of 242 unilateral group, and then 128 in the contralateral nodule group. And you can see that survival didn't matter. So contralateral benign nodules had no impact on the natural history of disease in this study. So when you're seeing contralateral nodules, I think it's not a definite that they require surgery. It's just a definite that they have appropriate surveillance, and then based on ultrasound characteristics and size, whether or not you even FNA that, but does not necessitate an automatic completion thyroidectomy. What is the optimal TSH target? So our 2015 guidelines said we should keep ATA low-risk patients who have undergone lobectomy 0.5 to 2. Weak recommendation, low quality evidence. And then for how long as well. There's a great study published in Thyroid 2022 of almost 2,300 patients who had a lobectomy for PTC, and all were recommended to have a TSH goal of 0.5 to 1. And then they analyzed the mean TSH during follow-up, and it showed that TSH was not associated with recurrence when the TSH was under approximately 4. So keeping the TSH within the normal range over this time of follow-up did not show an increase in recurrence in this low risk category. So their recommendation was a normal range TSH is recommended for those who have low risk, no concerns of recurrence, and have undergone lobectomy. So how'd this patient fare? Well, they're 5 years after surgery. They're not on levothyroxine. The TSH is 2. The thyroglobulin is 42.7. And most importantly, ultrasound just shows a mild growth in the 13 millimeter TI-RADS 3, but no abnormal lymph nodes. So we have to ask ourselves, what would we do? This is not my patient. This is Dr. Stephanie Fish's patient, and this patient did not go for completion and has not had an FNA of that nodule. Okay, I'm going to transition into case 2. It's a 35-year-old female with a palpable thyroid nodule noted on physical exam. It seems like it's always the dentist or the gynecologist that finds these, or the PCP, but dentists and gynecologists do a great job feeling the neck. Ultrasound shows a 2 centimeter suspicious right nodule, TI-RADS 5, normal left lobe, no contralateral, no lateral compartment, abnormal lymph nodes. And clearly you can see the suspicious nodule there. This is biopsied and diagnostic of papillary thyroid cancer. This person undergoes and chooses to do a right hemi-thyroidectomy. Pathology reveals a 1.9 centimeter papillary thyroid cancer tall cell variant. It's encapsulated with no capsular invasion, no vascular invasion, no extrathyroidal extension, and negative surgical margins. 6 weeks after surgery, a thyroglobulin is 7.8 with negative antibodies. TSH is 2.44. So what do we do next? Would we recommend completion thyroidectomy? If we do we give them radioactive iodine ablation? We know from the ATA guidelines that aggressive histology, such as tall cell variant, particularly if the larger majority of the cells is an intermediate risk. And an intermediate risk, we often consider total thyroidectomy with radioactive iodine. But our guidelines support starting with a lobectomy, and now we have this pathology and we have to make a decision of what to do. Well, if you look at the ATA guidelines, based on high-risk features on surgical pathology, this would lead to completion in 43 to 58% of patients with after thyroid lobectomy. So that's a lot that would require a 2-step procedure. So we have to ask ourselves, is more surgery necessary, and what's the evidence for that? So let's look at a few studies on adverse histological features and are they really bad in terms of outcomes. So this is a meta-analysis of 29 autopsy studies, including 8,700 patients. Occult thyroid cancer is found in about 8.5%, so good thing to know. Adverse histological features in those 740 subjects found at autopsy to have thyroid cancer showed 18% had minimal extrathyroidal extension, 27% had multifocality, 11% had vascular invasion, and almost 10% had lymph node metastases. So clearly, these people did not die of their thyroid cancer despite having adverse histological features. So perhaps they don't always, the thought was maybe markers of aggressive disease may not be an indication for completion thyroidectomy, as these patients went on to die from something else. Here's a study of 2,000 thyroid cancer patients with high-risk features, including tumor greater than 4 centimeters, gross extrathyroidal extension, macroscopic multifocality, lymph node metastases, and 1,200 had lobectomy, and 835 had total thyroidectomy. Lobectomy in this study was not associated with significantly worse outcomes over this follow-up time period of 120 months. We can see here from disease-specific survival versus recurrence-free survival on the bottom that there's no statistically significant difference between the two groups. This study is a little newer, looking at lobectomy versus total thyroidectomy for node negative T1T2 tall cell variant, which is exactly what this patient had. And they showed that over this follow-up, longest of 120 months, that there is no overall survival or local regional recurrence rates in patients who underwent lobectomy versus total thyroidectomy for this tall cell variant. Again, T1, T2. So some evidence we can discuss with the patient. And this is a well-done study looking at, is radioactive iodine always necessitated for tall cell variant? And what this looked at was survival for tumors that were at different sizes. And what it showed was if it's under 2 centimeters, there's no difference in survival in those receiving total thyroidectomy plus radioactive iodine. But for larger tumors, there was. So maybe for smaller tumors, we don't have to jump to completion or radioactive iodine, as some studies have shown there's not a benefit. Okay. But would my decision change if molecular testing showed a BRAF V600E mutation? What about a TERT mutation? In the days of molecular testing and all that we have, we often know this, where before we didn't. I will say here at UCSF, almost 85% of our patients have BRAF V600E versus when I was at Duke, it was about 45%. So it's a lot of it depends where you're at. So does the BRAF gene itself alter risk? Here's a study of 955 patients with solitary intrathyroidal PTC, less than 4 centimeters. In this study, BRAF is positive in about a third. All patients, recurrence was 8.1% in BRAF and 2.2% in wild type, kind of consistent with what our recurrence risk slide shows us in the guidelines. And there was less significant difference in recurrence as the tumors were smaller. And we've known this for a while, that when the lower the risk, the less pertinent the BRAF mutation comes. So tumors greater than 3 centimeters, definitely you see a big divergence in that top left graph. Tumors greater than 2 centimeters, a little still statistically significant, but less. But then in tumors that are small, you don't really see much of a difference. So the smaller the tumor, the less the difference in recurrence. But what if you look at TERT? So here is 685 patients, 78% had BRAF, 19.4 TERT. In the BRAF positive patients, cause-specific survival and disease-specific survival, there is no difference between BRAF positive and BRAF negative. But if you add in a TERT promoter mutation, very big difference in survival rates for these patients. So for this patient, 5 years after surgery, they're on 112 micrograms of levothyroxine, TSH is 1, TG is 2.4, negative antibodies, ultrasound looks clean. No suspicious lesions, no abnormal lymph nodes. And this patient chose not to undergo completion thyroidectomy. Okay, case 3. I like this case. 54-year-old woman, palpated neck mass. Looking back, I've seen in pictures 2 years ago. If you all Facebook friend me, I will find all your friends with thyroid nodules and message you. Ultrasound showed a 3.8 centimeter thyroid nodule, ThyRADS 3, left lobe was normal, no suspicious lymph nodes. Biopsied, it's Bethesda 3, and gene sequencing shows it has an NRAS mutation with a 75% risk of malignancy. So she undergoes lobectomy. It shows a 3.4 centimeter follicular carcinoma, minimal capsular invasion, no extrathyroidal extension, but 2 vessels of vascular invasion. At post-op, TSH is 1.8, thyroglobulin is 22 with negative antibodies. So just want to take a minute and talk about the significance of vascular invasion, how many vessels matter. Is surveillance different for papillary versus follicular thyroid cancer? And how helpful is ultrasound? As we know, probably less than 12% of follicular thyroid cancers will recur in the neck and spread hematogenously and often have more distant metastases versus local regional recurrence. So just a quick reminder, who just has their 5th edition now to define follicular patterned tumors. I'm not, in the interest of time, I'm not going to go through this, but talk more about how we break down follicular thyroid cancer as this has been evolving over the last 10 years. We have minimally invasive follicular thyroid carcinoma, which is only limited to capsular invasion. And now we have this middle category, encapsulated angio-invasive follicular thyroid tumors, where these have 1 to 4 foci of vascular invasion, but not greater than 4. And then widely invasive is tumors showing widespread invasion through the thyroid parenchyma or extrathyroidal tissues. And just to show some differences between WHO and College of the CAP group is how we define vascular, I lost my pointer, how we define vascular invasion varies a little bit, where WHO feels this one is a little controversial, but you need, where CAP feels like you need thrombus there. So just a nice schematic of what is included. And I think it's really important when your pathologist is reading these that it's a well-trained pathologist in thyroid pathology, because I've seen a lot of differences between institutions, especially non-academic institutions, on how they call these. So just real quick, MSKCC experience there from 2015, strong correlation between capsular vascular invasion and extensive capsular invasion, but only extensive equal or greater than 4 foci vascular invasion had an adverse prognostic factor. And our guidelines in 2015 listed minimally invasive follicular thyroid carcinoma, or those with less than 4 foci vascular invasion were ATA low risk. But there's been some studies that show even having 1 to 2 foci or 3 foci of true vascular invasion does carry a higher risk. This study published in 2011 showed a higher risk of distant metastases with even just 1 to 2 foci. This study by Liang and World Journal of Surgery in 2022 showed the risk of distant metastases greater than 4 foci was 31%, which doesn't surprise us based on other studies, but less than 4 foci was 6.3% versus 3.6% in minimally invasive follicular thyroid cancer. So I think the story from this is you're not completely out of the woods if you have even a few foci of vascular invasion. And some of the things that predicted distant metastases and recurrence for follicular thyroid carcinomas were male sex, being older, larger tumor, and then more capsular invasion, more vascular invasion. So it's kind of a continuum. But in this study, there was no difference in distant metastasis-free survival and disease-specific survival statistically. So it was a rise, but it wasn't statistic, and clearly a difference with the greater than 4 foci and the widely invasive. And tumors greater than 3 centimeters in age greater than 50 were associated with more metastases. So in summary, how many vessels matter? In 2015, ATA, and 2017, WHO, vascular invasion with or without thrombus greater than 4 vessels is the threshold, but I'm showing you some other studies that suggest there's a risk of distant metastases with less than 4 vessels. So just food for thought. College of American Pathologists update in 2022 felt that the thrombus is required. So they felt the use of appropriate criteria seems to be more critical than the number of involved vessels. So how our pathologists call vascular invasion, it becomes incredibly important to risk stratify these patients. So when I think about it, consider age, gender, size of the tumor, preference of the patient. Because these patients are more challenging to follow. So thyroglobulin and follicular thyroid cancer. So in papillary thyroid cancer, ultrasound is our absolute cornerstone of surveillance in patients who have undergone lobectomy. But in follicular thyroid cancer, it's not. So how do we follow thyroglobulin levels if we do it all after lobectomy for follicular thyroid cancer? And does it help detect distant metastasis? The literature on this is incredibly sparse. I actually spent a lot of time re-looking to make sure there's nothing out there, and it's not very good. So some indirect data. There's a study looking at lobectomy for follicular adenoma who later presented with distant metastases. There's 2 of those. And one showed in 6 cases diagnosed well after 2 to 37 years later that thyroglobulin levels were quite high, 246 to 3,300. And then Lee et al. In the second case showed thyroglobulin greater than 500 9 years after lobectomy. And this has been consistent with what I see in my practice. The patient has surgery, they think they have a benign follicular adenoma, are told not to worry about it, and then they come back 9 years later and they have bone mets or lung mets. Well, how helpful is ultrasound in follicular thyroid cancer? So like I said, probably less than 12% will have regional metastases in the cervical lymph nodes. So this is a smaller study. I think it was only 32 patients, single institution, looking at if this is stratified by American Thyroid Association low risk in the first bar and high risk and then unknown risk. That very few people showed up with positive ultrasounds despite recurring. And then here is a thyroglobulin excellent response versus incomplete response. So really, ultrasound was not very helpful in this study. And not surprisingly, since follicular thyroid carcinoma doesn't typically spread local regionally. So this patient, they had a right lobectomy. They have 2 vessels of vascular invasion, 6 weeks post-op. TSH was 1.8, thyroglobulin was 22. And the discussion with, I think we really need to think about this as a discussion with the patients of the pros and cons of radioactive iodine. One thing I didn't go into talk to is whether patients will be committed to thyroid hormone after lobectomy. A couple of the patients I showed you had TSHs over 2. It'll be interesting to see where future guidelines go. Right now, our guidelines suggest we should keep TSH 0.5 to 2 in our low risk patients, but I showed you some data that didn't show a lot of difference. And we all have patients with varying degree of risk and response. We did a study, Dr. Amati and I at Duke, looking at what % of patients actually need thyroid hormone after lobectomy versus those with and without thyroid cancer. We all know that it's about 30% in the general population if you're starting with a TSH under 3. But if you want to keep everyone 0.5 to 2, in our study, we found that it's actually about 67% if you're aiming for 0.5 to 2 will require thyroid hormone. So it may not be as great of a avoidance reason to consider lobectomy over total thyroidectomy. So what if there was no vascular invasion in this tumor? What if it was 0 vessels? And what if the tumor was larger? So I'm throwing a spin on the case. What if it was 4.85 or even 6 centimeters? Would we recommend completion thyroidectomy for a minimally invasive follicular thyroid carcinoma, 0 vessels of vascular invasion, and the tumor is large? Well, there's this thyroid study coming out that's ahead of print, and they looked, they commented that differentiated thyroid cancer greater than 4 centimeters is staged as a PT3, and current ETA guidelines recommend completion in consideration of radioactive iodine. But they followed 88 patients, retrospective cohort, with greater than 4 centimeter differentiated thyroid cancer that was encapsulated. They excluded tall cell variant, any vascular invasion. They excluded NIFP and any high-grade histology. 21% of this cohort was FTC, and they followed them for a median of 4.8 years. No recurrence was found in the entire cohort, and the 10-year disease-specific survival and disease-free survival were both 100%. So it raises the question, are we right about all tumors greater than 4 centimeter need to have a completion thyroidectomy followed by possible radioactive iodine? So in my 20 years of doing this, it's always so fascinating to me to see where the science takes us. And I think it's important that we understand the quality and the level of our evidence. And thyroid cancer is such a great thing to see as a clinician, because to me, it's so individualized and it's so dynamic. So glad to share a few cases with you today on that. So in summary, lobectomy is an acceptable primary treatment strategy in qualifying patients, particularly those with tumors under 4 centimeters without gross extrathyroidal extension or clinical lymph nodes on ultrasound. Always has to be a discussion of weighing the pros and cons with your patients. Are they averse to having a 2-step procedure if needed? Are they averse to thyroid hormone? What does the contralateral lobe look like? What will surveillance look like because of that contralateral lobe? Do they have access to a high volume thyroid surgeon? That's a very important decision for a lot of our patients, since 75% of thyroid surgeries are performed in the community. And we know that drastically changes outcomes and risks. I've shown you several studies, and there's many more out there that have shown equal outcomes with lobe versus total thyroidectomy and less risks of total thyroidectomy, such as post-surgical hypoparathyroidism, et cetera, and the need for thyroid hormone. But surveillance of these patients may present challenges. So much of our data was based on the old days of taking out everyone's thyroid and giving them radioactive iodine, and then thyroglobulin is highly reliable, particularly in those with antibody negative status. And now thyroglobulin levels are very controversial, whether they're helpful in patients who have had a lobectomy, and the evidence is very weak about following it. And then ultrasound in follicular thyroid carcinoma, ultrasound surveillance isn't as helpful. So if we're not following thyroglobulin and we're not doing, ultrasound isn't as helpful, what do we have to offer these patients for that small percentage that do recur? So it can be really challenging. I think it requires a lot of individuality into the patient and how to develop their active surveillance strategy. So I presented 3 cases. I think it's important to know when to proceed with completion or radioactive iodine based on pathology and patient preferences. But like I said, it's very individualized and can be very challenging to come to. So with that, I'll pause and take down my slides and open it up for discussion.
Terrific, Jen. Thank you very much. Great review here, and really some important pearls on an evolving landscape for how to manage these patients. I do want to just reach out and encourage any of our listeners to send in their questions. There's a lot of material here to cover. So Jen, let me just ask you, this was really terrific. There is a psychology involved for the patients, and I mean, it's a sort of a similar psychology when facing the decision for no surgery versus surgery, and in the very low risk patients with thyroid cancer or suspicious nodules. How do you size that up, and how do you manage those patients in terms of this decision?
How do I manage patients that want to go active surveillance without surgery?
No. So just sort of sizing up the patient and their desires, because that weighs in on this decision of lobectomy versus total for those that where it's a question.
Absolutely. So first, I just want to say my practice is potentially skewed compared to others on this call. And I work at a tertiary quaternary institution. So we often see patients that have much more comorbidities that provide like precedence and need to be treated first. So comorbidities, age, risk averse. I just go through the data. We can do this, we can do a lobectomy. There's a chance this could happen. The risks are this. So I think sizing up the patient of what's their prognosis overall is very important when you're at such a TQ place. What is their risk averse attitude towards this? And then going over the risks and benefits and how we will surveil them afterwards, and then coming to a decision. And I think that also needs to be a discussion with the surgeon. I'm an endocrinologist, so I have that discussion, but so doesn't my surgeon. I think that's very, very important. And then I'm also on the other part of the fence, I'm a little more spoiled because I have access to very high volume thyroid surgeons. So I know when I send my patients, the risks are low with either procedure versus maybe patients that don't have access to high volume surgeons.
Great. We have a question from one of our listeners regarding the decision to perform molecular testing and whether you do it based on histologic or cytologic subtypes.
So reflexively, the only testing we do here at UCSF is indeterminate nodules get sent for thyroid cure. We do not send Bethesda 5 or 6. We do reflexively test for BRAF for all nodules, all tumors at pathology greater than a centimeter. Like I said, 85% are positive here, so it's a very high positive for that.
Okay.
Oh, and I will say we, in patients who have advanced disease, we have something called UCSF 500 or Tempest or whatever the insurance will cover, genomic profiling for our advanced patients to look for targeted therapy.
Great. So the decisions to do a completion thyroidectomy versus after the fact versus intraoperative decision making versus preoperative assessment, that's a little bit, those are slightly different points in the journey here. And so your thoughts regarding intraoperative findings of strat muscle involvement. What would be intraop T3B determination, or the finding of positive lymph nodes. Can you comment on that and maybe what guidance you would give? It's different when you're in the thick of it and you're making real-time decisions versus committing a patient to go back to the operating room, undergo a second anesthetic and another operation.
Yeah, I'm speaking a little bit for my surgeons here, being an endocrinologist, but here at UCSF, all of our patients have that discussion up front and are consented for both. So our surgeons will do their best to move directly to completion while in the OR if they find concerning findings, as long as the patient allows it. So that's just how we approach it here. And then generally, if we don't go back within 2 weeks, we usually wait 6 to 8 weeks to go back for completion.
Okay. Can you comment just a little bit on the decision to biopsy a contralateral nodule in a patient with a biopsy-proven less than 4 centimeter thyroid cancer? Is your threshold? Do you make that decision strictly based on ultrasound features and a discussion with the patient? Is your threshold different in that setting to actually perform a biopsy?
Yeah, I mean, I certainly think ultrasound features matter a lot, because if it's clearly spongiform, I think weighing whether to do that or not is very different than if it's a TIRADS 4 nodule and maybe a little bit smaller. So if it's all risk assessment, if it's really going to make a huge difference in the patient deciding on, I want a total versus a lobe, if my cutoff is 1.5 centimeters and it's 1.4 centimeters, of course, I may offer a biopsy to make that decision up front so the patient doesn't have to have a 2-step procedure. So I go mostly by ultrasound features, and then some will be on the fence. And if it really makes a big decision for the patient to go for completion, we'll biopsy it.
And will you, if it's an indeterminate cytology on that contralateral nodule, will you go to the extent to get molecular testing to make that decision of total versus a lobectomy? Or are those patients ones that you would commit to a total?
I haven't had that come up a lot, but I suppose if it did in my practice now, if the patient saw that and was committed to total, I probably wouldn't have the ThyroSeq sent, because we would be doing a total. Why spend the money? But if the patient was saying, no, I need to know this, whether to do a total or not, I wouldn't see a harm in sending it.
Okay. All right, terrific.
Especially if it was, Bethesda 3 and didn't have high risk features on ultrasound.
Right. Well, listen, thank you very much. This was really an awesome review. I can't thank you enough for getting up early and starting your vacation with us. So thank you. And I hope that we can call upon you again. This was absolutely terrific. Thank you so much.
Thank you for having me.
You bet.
Here.